All right. So like I said, your diaphragm, every time you breathe in, your diaphragm is going to contract downward. And that contraction, when it goes downward, is going to make that negative pressure, which will suck the oxygen, the air in, which has the oxygen in it. So you can breathe it and it can go down into your alveoli. So it says here, during normal respiratory cycle, diaphragm and other parts of the body work together to inhale and exhale. So apart from the diaphragm, what other main muscle is used during normal respiration? Anybody can answer this.
The intercostal muscles.
Exactly. And what are the intercostal muscles, like in layman's terms?
Muscles between each and every one of your ribs.
Yeah, exactly. All right, so see respiratory anatomy and physiology. So right here, that's your diaphragm. Again, it's gonna go downward, and when it goes downward, it's like it's pulling air down. That's what that negative pressure is. So every time this goes down, air is sucked in from your mouth, and that's what negative pressure is. At the same time, the intercostal muscles along the in between your ribs are going to go outward, and that is also going to create more negative pressure, which will suck in more oxygen to reach the alveoli. Okay, so it's an active process. All that means that it being an active process, that just means that you have to use your muscles. You have to work to breathe in, all right? Uses muscle contractions to increase size of chest cavity, and that's where our negative pressure is created. Intercostal muscles and diaphragm contract. So these are your main muscles that you use during normal respirations. As a pediatric, your pediatric patients, so your infants and your toddlers, they use more of the diaphragm. That way, have you guys ever seen a baby? We call them sometimes belly breathers, because every time they breathe, the little belly goes up and down. That's them using their diaphragm for the most part. Because obviously, as an infant and a toddler, their intercostal muscles aren't strong enough yet to participate and take some of that load from the diaphragm. So diaphragm lowers, ribs move upward and outward. Talked about that, and the air is pulled into the lungs. All right, so expiration, passive process. Passive process just means that you don't have to work for it. It happens without you having to contract any muscles or anything of that sort. So the rib muscles and diaphragm, they just relax. And as they relax, your thoracic cavity, and Seth, what is the thoracic cavity in layman's terms? What is that?
That's your chest.
Your chest, perfect. So as your muscles relax, your diaphragm and your intercostal muscles, your rib muscles relax, the thoracic cavity is going to shrink. So as it's shrinking, going more inward, that's going to create that positive pressure, and that's going to push the air out from your mouth. So size of chest cavity decreases, air flows out of lungs, like I said. So adequate breathing is what most of us should be doing right now. Just normal breathing is going to support life. And if you have adequate breathing, you should not, under normal circumstances, be able to notice that a patient is really breathing, because it's effortlessly. It just happens. We just do it automatically. So no obvious distress. Obviously, we talked about that. Ability to speak in full sentences without having to catch his breath. Now, when your patient is in respiratory distress, there's in respiratory distress, and they are struggling to breathe. Sometimes these patients will talk in a 3 to 4 word sentences, and it's because they have to catch their breath in order for them to keep on talking. Now that would be that would obviously be inadequate breathing, right? They're still able to talk to you and communicate during respiratory distress. They're not mentally altered, but they're still having difficulty breathing. And then when they shift from respiratory distress to respiratory failure, that's when you start to see that mental status shifts. So see, with adequate breathing, you have normal color. Mental status is gonna be good. There'll be ANO times 3 or 4, and orientation. So as far as mental status, if your patient is relatively a normal human being and they are breathing adequately, on that AVPU scale, alert, verbal, painful, or unresponsive, Desiree, can you tell me where your patient would fall? Under which one of those they might fall? If they are a normal patient, is a normal human being, and they are breathing adequately. As you approach this patient, you think they're going to be A, V, P, U, a combination of one or two? What do you think?
They're normal, right? So they should be like the first two, the AAV.
Yeah, exactly. Now they may be alert. It's what we want. We want alert, right? We want to be alert. So we want them tracking us as we're walking. But sometimes, they're distracted or whatever the case may be. So verbal stimuli. And then if my patient is either alert or verbal, Jessica, I think you're here. Yeah, Jessica. What can I use to expand on me knowing whether this patient is oriented or not? Like, what else aside from AFPU can I use to kind of get a better idea of where my patient's mental status is?
You can use ANO times 4 maybe?
Perfect. That's exactly what I was looking for. Yeah. All right. So if you guys don't have these numbers down, please write them down. So these are adequate breathing rates for your adults, children, and infant. Of course, if your patient is out of range from any one of these, 12 to 20, 15 to 30, 25 to 50, it doesn't mean that they're having some kind of respiratory emergency, all right? They could just be out of breath. So don't just take the numbers don't just take the numbers into consideration. Also take your patient's mental status, what they're doing, the condition, the environment, all that plays a factor, and you're deciding on whether your patient's breathing is actually adequate or not, all right? These numbers aren't just gonna tell you about them by themselves. And that makes sense, right? I mean, it's common sense. Like, yeah, they might be breathing 30 per minute, it's an adult, but they might have just gone for a jog and they're talking to me just fine. So I'll give you guys a few seconds, write these down. If you don't know them, you have to at least have an idea of the range. Of course, rhythm usually is regular. Again, environmental factors play into that, but it's gonna be a regular rhythm. Breath sounds normally presents and present and equal. So when they're saying this, breath sounds normally present and equal, we're talking about when you're auscultating the patient. Who here can tell me what that means? What is auscultating? What does that mean?
Listening to.
Listening, yeah. Is Andrew here? I think Andrew's the one with the iPad, right? It's the iPad.
Yeah.
Yeah, and can you break that down for me more? We're listening when we're auscultating, but break it down just a little bit more.
It's when you put the stethoscope to the front of the patient and to the back to hear for lung sounds.
Yes, exactly. So we're listening to the lung sounds with a stethoscope. That's what we're talking about. Okay, so now we're shifting to inadequate breathing. So obviously, inadequate means it's not good enough to support life. So breathing is not sufficient to support life. So the rate is out of normal range. So again, if it's your adult patient, they're breathing below 12 per minute or above 20 per minute. Again, take the patient's condition into consideration, not just the number. Irregular, rhythmic. So whenever you have irregular breathing, usually, and obviously there's a whole bunch of different scenarios out there, but usually from my experience, these patients that have irregular rhythm, usually it's either going to be some kind of head issue, head trauma, or some kind of thoracic cavity trauma, which causes the abnormality. Okay, do you guys have any questions about that? Irregular rhythm? No, okay. So also, as far for inadequate breathing, you have diminished or absent lung sounds. Diminished just means that they're barely even breathing. Their chest cavity, the thoracic cavity, the intercostal muscles, and the diaphragm are not contracting good enough to create that negative pressure to suck that air in. So that's what diminished means. It means that they're just not breathing enough. They're not creating enough capacity, I guess, in their chest to have that air sucked in. And absent lung sounds is just what follows after diminished lung sounds. Obviously, they're not going to be breathing. Poor tidal volume. So again, poor tidal volume is pretty much the exact same thing as diminished lung sounds. Because if you have diminished lung sounds, you have poor tidal volume. So diminished lung sounds means that you have poor tidal volume, because who can tell me what tidal volume is? What is tidal volume by itself when talking about the respiratory system?
That's the amount of air?
Yeah, so that just means tidal volume is the amount of air you breathe in and breathe out in one cycle. So if you have poor tidal volume, not enough air is coming in, obviously your lung sounds are going to be diminished. All right. So we talked about this before again in our anatomy and physiology chapter, and that is that the difference between pediatric patients versus adult patients. Their excuse me, their mouth structure is made to where they can have objects obstructing the airway much easier than a patient. So like how it says here, smaller airway, easier to obstruct. The tongue is larger than the oral cavity in proportion to us adults. So as we get bigger, this is the best way to kind of maybe remember it, right? It's just kind of like in layman's terms, just simplifying everything. So a good way to think of it is that as you get older, after a certain age, your tongue doesn't grow, but your mouth continues to grow, the actual oral cavity. So in proportion, pediatrics have a bigger tongue than their mouth. Adults have a smaller tongue than their mouth. That's just an easy kind of way to kind of put it for some of you guys. What? What was that? You all right?
My bad, we're good.
All right, cool. All right, so smaller, softer, and more flexible trachea. And David, what is the biggest issue with a smaller, softer, more flexible trachea as far as like us taking care of the patient? And like airway management, like the airway management portion of that. What are we worried about here?
We're worried about it being kinked up or.
I'm sorry, you kind of break down. One more time.
We're worried about it getting kinked up or
I heard it that time. Perfect. Yeah. So if we were to overdo it with our head tilt chin lift, we can actually kink that trachea, and now we are the obstruction. So that's one thing to look out for, especially with your infant and toddlers. Less developed, less rigid cricoid cartilage, along the same lines as that. Heavy dependence on diaphragm for respiration. So like I said, a lot of your toddlers and your babies, you'll see the stomach go up and down. That's because they're belly breathers. They use their diaphragm primarily for breathing. All right, so signs of inadequate breathing in infants and children. Nasal flaring is a big one. If a kid is having issues breathing, like real issues with respirations, nasal flaring is a big giveaway. The seesaw breathing that you see here, that is in regards to them being belly breathers. So you'll see their stomach go outward really, really, really hard, and then just suck right back in. And because of their chest, it looks like a seesaw movement. But unlike adults, we have what's called accessory muscles, right? Like our traps and our back. So we can use those to like create more negative pressure, to make the chest bigger, to suck more air in. They can't do that. So they're gonna just try to really, really contract that diaphragm downward even more to bring in as much air, and that's where that seesaw breathing comes from. As far as retraction goes, that's their little intercostal muscles like trying to breathe, trying to work. So you'll see their skin retracting, and you'll see their ribs kind of sticking out. They'll be kind of popping out because of the difficulty breathing. And I did find a video on here showing an infant with difficulty breathing. So I'm gonna share that with you guys. Let's see, I go back on here. Any questions so far, guys, about anything that we're going over? No? All right. Oh, I gotta stop sharing. Sorry. Oh, wait, let me see. Do you guys see the change? Do you guys see it? Is there a change in the screen?
No.
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 No? Okay, then I gotta stop sharing. Oh, we have a new share option. Let's see. Share. Do you guys see that now? The YouTube video?
Yeah.
Yeah.
Perfect. All right. So here's a.
Yeah.
Okay. So you'll see the nerve. You see that right there? Okay. Any questions about that video?
Nope.
Nope. All right. You are you. Let's go back to the PowerPoint. Okay. All right, patient care, inadequate breathing, assisted ventilations with supplemental oxygen. So obviously, if your patient is not breathing adequate, right? They are not breathing adequate. That means that they're not breathing adequately enough to sustain life. So with that being said, do you think you might have to help in assisting with ventilations to sustain life? The answer is yes, right? So if they're breathing inadequately, that means if you ever see your patient is not breathing adequate enough to sustain lives, that means you have to assist them because they're not breathing enough for themselves. So your options here are going to be in the EMT out in the field is your pocket face mask, which we went over the first 2 days, right? How to use that with supplemental oxygen. So some of these face masks that you have like a little, I don't even know what to call it, but like a little prong sticking out of it, and you can hook up your O2 to that to even give them more oxygen on top of what you're delivering. And obviously, if for a bag valve mask, there shouldn't be more than you can only use the BVM technically if there are 2 or more rescuers. All right. So if you're by yourself because your partner had to go to the rig real quick or had to go do something, call for backup, you're only going to use your pocket face mask. Okay. Now when it's you and your partner and even more rescuers, you shift over to the BVM. And that just has to do with the fact that the American Heart Association doesn't think that it's efficient enough for one rescuer by themselves to use the bag valve mask, as far as like time goes and stuff like that.
Why couldn't you just use a non-rebreather? Is this for like a patient who is who's already passed away, or is this?
Yeah, so that's a good question. So that's what it comes down to. So your patient. So if you're using a pocket face mask or a BVM, a bag valve mask, it's because your patient is pretty much to the point that they can't breathe adequately on their own. So this patient is going to be either mentally altered, unconscious, or about to crash. Like you're seeing this patient actively decline. You know what I mean? Like that's the kind of patient.
Yeah, I got it.
Yeah.
Okay.
Yeah. Now, if you have that patient that is having difficulty breathing, or they can still talk to you, even if they're catching their breath, but they're not mentally altered and they're not passed out, then that's the patient that does get the NRB because they're not mentally altered. They're still communicating. Yeah. Does that make sense?
Okay. Yeah. Thank you.
All right, cool. All right, so adequate and inadequate artificial ventilation. So for your adult patients, you want to breathe for them 12 per minute. So that's one every roughly 5 seconds. One ventilation every 5 seconds, right? Now for your pediatric patients, it's 20 breaths per minute for infants and children. Who can tell me why there is a difference there? Why that difference exists?
Because children and infants breathe more normally on them by themselves.
They breathe at a much faster rate than adults. And the reason is because they're not as efficient as we are. So our bodies, when we grow up, they're more efficient with oxygen. All right. So we don't need to breathe as much per minute. Pediatrics don't have that. They need much more intake of oxygen to fill their bodies up, because they also have less volume in proportion to us. By volume, I mean blood in proportion to us. And because of that, we need to provide them with more oxygen. Okay, because they're used to getting more oxygen per minute than we are because they need it. Okay, any questions about that at all? No? Okay, now the one thing you don't want to do is you do not want to hyperventilate your patient, your adult patient. Hyperventilation, hyper again meaning too much or higher than, and ventilations are your ventilations. So hyperventilations just means that you're breathing for your patient higher than normal, like too much. And there are only certain times and certain scenarios where hyperventilation might be acceptable, and that's during head trauma situations. And we'll talk about that more when we get to that head trauma chapter. But I just wanted you guys to know that there are certain scenarios where it may be ideal to hyperventilate your patient, but on a normal, you don't want to. All right. What is this called right here? This position?
Tripod.
Tripod, yes. So your tripod position, what happens is when you're having difficulty breathing as a human being, is that your body it's automatically going to shift into survival mode, and it's instinctual. So what your body is doing by going in tripod is that it's lining up everything. It's lining up your airway and your mouth. And you're also leaning forward to allow your accessory muscles to just do their job and go outward and upward. When your traps go upward, your back goes outward. And that's what the body's doing when this is happening. This is an obvious sign of someone catching their breath, whether it's a medical condition or they just had a really good run. All right, so now we're going to OPQRST, and this right here falls under the secondary assessment of your medical assessment. So onset, so when did it begin? That's just good to know for timing. Provocation, what were you doing when this is on? So the reason that this provocation question really helps you out is because it lets you identify whether maybe it's the difficulty breathing is from exertion. Were they working out? Maybe they're not used to working out, or was it just a sudden onset? Did it just happen? And that really matters as far as medical treatment. Quality. Quality when it comes to breathing and difficulty breathing is more of what you see. It's more objective than subjective. So it's not really what the patient is feeling as far as breathing goes. When it comes to pain, it's a little different. But as far as breathing, you have to shift over to objective, and it's what you see. Is the patient coughing? Are they bringing anything up? Any sputum? Any mucus? Anything of that nature? Radiation, you just want to know if the discomfort is shifted anywhere else, just to kind of give you a better idea of what's going on. Maybe lead you in a different direction than what you're thinking, because we do get that tunnel vision sometimes as medical providers. We have this one thing in the back of our head, and we just think it's that because we're taught a certain way, but sometimes it's not.
I thought provocation was like, say for instance, it's if they're doing something that makes it feel any worse to their body.
Yeah. So it's a little bit different when we're talking about respirations, because it's kind of like so OPQRST is really good for pain. OPQRST is really good for your cardiac patients. It's tailored for a cardiac patient. but they also want to use OPQRST for breathing emergencies. And I think the only reason this is really done is just to kind of standardize the NREMT testing. Does that make sense? But the way, yeah. But the way you were thinking is exactly the way you should be thinking. And OPQRST is perfect for your cardiac patients, and it's tailored for cardiac patients. This is more like we just want to make it work, you know?
Perfect.
Gotcha. All right, so severity. Now, on a scale of 1 to 10, I guess the discomfort for the patient. Now, this obviously is not gonna help you out that much because it's more of what the patient feels, and everyone feels things differently. But it helps you because it lets you know if the patient is getting better or worse or staying the same. Because based on how they feel when you ask them this question initially, when you reassess them, did it get better or worse? And that's really how this helps you as far as patient care goes. Time, how long have you had this feeling? And again, this goes back to they're trying to make it fit because time and onset are the same thing. But, you know, just the way it is.
So for critical patient, how often are you taking vitals for like would it be for a critical patient, would it be like every 5 minutes or every minute?
Yeah, so for like test purposes and stuff like that in REMT, every 5 minutes at least. But in real life, you're gonna have some patients where like you just instinctually know, like I gotta watch this dude like every minute or else he might die on me, you know? But no longer than 5 minutes. No longer than 5 minutes, yeah. So patient's position, so observing altered mental status. We talked about that, so I'm not gonna talk about altered mental status. But if you guys have any questions about any of these things, and I'm not talking about them, just ask me, okay? Patient's position, tripod, again, that's the body's just natural reaction to having difficulty breathing. Sitting with feet dangling, leaning forward. To me, that sounds just like the tripod position, except you're sitting on something high. So, all right, guys, let's take a little 10-minute break, and we'll get back to it, all right? So I'll see you guys in 10 minutes.
Great.
All right, guys. Here we go. Well, let me see if anybody else is try to join the. No, yes. Something. All right. Talked about that. Just saying. All right, so breathing difficulty. So some signs: observing pale or cyanotic skin. So where is this patient going to be cyanotic? Most likely, Michaela.
No lips,
The lips. In severe cases, fingertips.
fingertips.
Yep.
Sorry.
No, good job. Thank you. Now, when the patient is breathing, is having difficulty breathing, who can tell me why pedal edema would even matter? Like, why pedal edema? First of all, means swelling of the ankles. But why does that matter? If your patient is having difficulty breathing, what is that a telltale sign of? Anybody think they may know?
I think does it have to do with? I'm just taking a guess. Just water.
Go ahead. It's actually, they have cardiac heart failure. So when the patient has heart failure, blood is taken to your heart from the bottom of your body via the inferior vena cava. Remember that from the last chapter that we talked about? So the inferior vena cava carries blood to your heart from the bottom of your body. Now, if you have heart failure, all heart failure really means is that your heart sucks. It's not pumping as good as it should pump. So what does that mean for your patient? That means that they're gonna have blood backing up. So if your patient has heart failure and on the right side of the heart and blood is going backwards, gravity takes over, right? And the blood pulls down and it settles on the ankles of the patient. That is pedal edema and it's from heart failure. Now, on the left side of the heart, the exact same thing is happening. If it's heart failure, it's heart failure all the way around. If they have heart failure on the left side of the heart, blood is being backed up into the lungs because blood is taken to the left side of the heart from the lungs, right? After it gets oxygen. And if blood is being backed up into the lungs, they're essentially kind of like drowning themselves because their blood is pooling in the lungs and that interfering with that gas exchange. Okay, and so that's a hint that if they're having difficulty breathing, they have pedal edema. It's a possibility that that's the reason why. It's because it could be linked to cardiac heart failure. Any questions about that? Nope. All right. Let me make sure I'm still okay. I'm still recording. All right. So oxygen saturation, reading less than 95% on the pulse oximeter. So again, if you don't know this now, you want your patient's O2 sat ideally to be between 90, 95, and 99. I would write that down if you don't have that down. If your patient's O2 sat is below 94, it's a good idea to put them on oxygen. Unless they have COPD and that they're normally like at a 89 or 88, in which case, most likely they'll tell you, or somebody will tell you.
You know, since you're on that topic, I know that someone that has COPD, if you give them too much oxygen, it'll kill them because they're not used to that much. Could you explain why?
Yeah, let me see if I can break that down, because it's been a while since I had to explain that. So normally, we have these things called chemoreceptors, right? So the chemoreceptors, they're on your aorta and they're in your carotid arteries. And what they do, the chemoreceptors, they measure the amount of CO2 in your bloodstream, NO2, right? And so what happens is that whenever let me see, hold up. So CO2, whenever CO2 increases in the bloodstream, when the CO2 increases in the bloodstream, your chemoreceptors send a signal to your respiratory center, and that's in your brain. And it sends a signal to increase respirations. And that's on a normal person. So chemoreceptors will measure the CO2 level, and the CO2 levels get high, then the chemoreceptors will send a signal to your respiratory center so that you can increase breathing. Now, on patients that normally have high amounts of CO2, being your COPD patients, they normally have a high amount of CO2 and lower than average oxygen level. Now, so that will reverse. So instead of going off of your CO2 levels, now we're going off of your oxygen levels, because it just shifts on them because they're used to having high amounts of CO2 and low amounts of O2. So on your COPD patients, whenever you give them too much oxygen, because they're used to having low amounts of oxygen percentage, their chemoreceptors will stop sending that signal to the brain to increase respirations, because they're going off of their O2 levels now. So if the O2 levels are higher than normal, now the patient's body is thinking, well, then now I don't have to breathe as much because I have a high O2. Does that make sense, kind of?
Yeah, it makes sense.
I know it's a little complicated, but I try to make it simple. But that's fine. All right, so this patient, here you go. Tripod position, and it's pretty much just pointing out where you would find certain things, but it's pretty obvious, like wheezing, flaring of the nose, cyanosis, you'd find it on the lips, all that stuff. All right. So breathing difficulty, observing noisy breathing, audible wheezing. So this is when you are walking up to the patient during the primary assessment. If you hear wheezing without you even putting on a stethoscope, that's obviously an issue, and they're having either most likely asthma, or it could be like a severe allergic reaction. Bronchi would be fluid in the lower airway, and it sounds like actually, you know what? Actually, found some videos. So let me show the videos on each one. First, wheezing, to give you an idea of what you should look for. Let's see. Is it this one? It's this one. Okay, so we don't want that one. Okay, here we go. So this is wheezing on a patient with asthma. First off, can you guys see this?
Yeah.
Screen? All right.
There's no sound. I don't know if it's supposed to have sound.
Well, there's no sound.
Yeah.
Yeah, there's definitely supposed to be sound. Let me see if I can fix that. Does anybody else not hear it?
I don't hear it.
I don't hear it.
Let me try it again. Try this one. You guys hear that or no?
No.
No.
That's weird. See, let me stop sharing and share it again. All right, share screen. Share that screen. All right. How about now? Still no?
No.
Man, I know. Yes, we were having that issue yesterday.
Are you sharing like your web browser screen or just your complete screen?
I don't know, to be honest. I'm gonna stop sharing and share screen. That's where I'm going. And select a window or an application. So I'm selecting that window. Share.
Does it let you select an application? Like, can you select YouTube as your app?
Let's see, advanced portion of screen, music, or computer sounds only. Oh, let me see. I think I found what's going on. Let me try it one more time.
I don't know about with Zoom, but with streaming, sometimes you have to share the actual application, not just your screen, to get the sound to come through.
I don't know, because yesterday we were using it. How about now? You guys hear it now?
No.
That wasn't happening yesterday. That's weird. That's not. Yeah, because yesterday the music was even playing and everything. Remember that? Yeah, let me try to figure it out, guys, real quick, and then we'll keep going. Moving controls. Share. Oh, here we go. I see what the problem was. All right. My screen sharing. All right. I think I got it now. How about now?
Yeah.
All right, perfect. All right, so this is wheezing. Here we go. So the sound you're hearing, that noise comes from when they are breathing out, because as your patient is breathing in with asthma, their airway actually opens up to allow air in, but it makes it difficult for the air to be pushed out, and that's where this wheezing sound comes from. Any questions?
No.
No? All right. All right, we talked about that. Gurgling. Let's see if I have a video on that real quick. I think I got one. Crackles, rails. No. Snoring. We know where snoring is from, right? Where is snoring coming from?
The upper airway, and it's like the
Fluid.
tongue.
It's your tongue. That's just when the patient's unconscious, muscle tone is relaxed, a tongue is a muscle, it flops back, and that's where that snoring sound is coming from. It's coming from that air coming out of your airway and just kind of flopping that tongue around. That's what it is. Stridor, is that an upper airway or lower airway obstruction?
Upper.
Upper, good. And that's normally from swelling in the upper airway. And then coughing, we know that's a trachea problem. That's more of a lower airway obstruction, usually. But let me show you this other video that I popped up. I think I have a few more to share with you guys as far as sounds go. So let me go screen. Okay, this is fine crackles, aka rails. You guys hear that?
Yep.
How about now?
Yep.
Yeah.
Okay, there you go. That's crackles. So crackles, or no, aka rails, is also referred to as a like bubbling sound, because it's fluid in the passages of your airway, and the fluid is just bubbling every time air goes through. That's why it's making that noise.
And since that has to do with someone with like early signs of heart failure, is that fluid in there gonna be blood?
Well, see, if a patient has crackles, that doesn't mean that they absolutely have or is going to have heart failure. That's just a possibility. But if it is heart failure, then yes, what is being backed up in the lungs is blood.
Okay, gotcha.
Yeah. The possible causes are right here. Bronchitis should also be one of them because you have mucus buildup. All right, and that's it for that. Here is stridor. And which patient will I most likely encounter this with? See, Drake.
Kids?
Kids. Yeah, your pediatrics, your little toddlers. Usually is that group.
And that has to do with because it deals with the trachea.
I'm sorry, hold on, let me pause this real quick. What's that?
And I said, is that because it has to do with the upper airway, so like the trachea and stuff?
Well, the trachea is like, that's where the lower airway begins. So it's above the trachea. So it's more like in
Your larynx?
Yeah, and that around that area. And it's making a high pitched sound. Sometimes it even sounds like a whistle, and it's because it's in the upper airway. And the reason that wheezing sounds like wheezing and it doesn't sound like a whistle is because it's so deep in your body that you actually hear the whistling sound. You just hear the whistling sound behind the barriers of your body. Mm-hmm. So it's the same issue, but except stridor, there's swelling up here, and with wheezing, there is swelling down here. That's the only difference. The swelling is in a different location. To keep it simple. Okay, take that off, and then we'll go. What is this? Okay, yeah. The reason I put this video up here, well, one, it's a really good clip, but also I want you to see how this. So this is a like a high school kid, more yeah, a teenager, and I just want you to see how he's in tripod. I want you to see how his body's reacting and just how agitated and uncomfortable he is, just so you get an idea of what your patient will present like. So here we go.
"15-year-old Chris is having a severe asthma attack. His immune system has made what could be a fatal mistake and is shutting down his airways. Without help from the medical team, Chris's body may shut down completely.
I'm not going to die. I'm not going to die. It'll be okay.
The breathing tubes in Chris's chest are squeezing tightly shut and filling with sticky mucus, blocking his vital oxygen supply. If he's not treated soon, he will die."
This is a really life-threatening episode of asthma. Asthma is pretty common in our community, and most of the time it's not this life-threatening, but this one is quite serious.
Chris's allergic reaction has tricked his immune system into shutting down his airways, blocking vital oxygen to the rest of his body. The drugs are supposed to help the muscles around Chris's airways to relax, but there is a problem. The mucus stops the drugs from reaching his blood supply.
Through the vein to try and help it out, because sometimes the lungs close down too much for this stuff to work. So.
Time is running out. Chris's body takes emergency action. His shoulders and neck muscles swing into action to help inflate his lungs. But even this is not working. As the pressure mounts, the team must find a treatment to get the drugs past the mucus. Chris is by no means an isolated case. 1 in 9 Australian children suffer from asthma, but for Chris, the situation is looking dangerous.
Chris is currently having Ventolin or salbutamol through a nebulizer, which he's breathing into his lungs. This acts on the muscles around the small airways and helps to open them up. Unfortunately, sometimes when the airways are very closed down, the salbutamol doesn't reach the areas that it needs to get to. The inhaled Ventolin is not working, then we often will go to a different form of medication. Again, a relaxant for the muscles around the small airways, and it helps to open those airways up, and it's given as a one-off dose over about 10-15 minutes in severe asthma.
Inside Chris's body, the airways start to open as the drugs take effect. Air finally returns to Chris's lungs, inflating the 300 million tiny air sacs.
Chris, feeling a bit better?
At last, he can breathe.
Chris seems to be feeling a lot better now. The intravenous medications seem to have taken effect. He still is very tired because he's been working very hard with his breathing, but we're a lot happier with his clinical progress now.
Chris was admitted to intensive care for 3 days, with a further 3 days in a medical ward before being sent home. He is now back at school playing soccer and is aware that it is important to look after his asthma and to tell his teachers and family when he's not well. Chris had always expected other people to look after his asthma, but after this emergency, he now understands that he must recognise when he is having asthma and follow his asthma action plan. Before leaving hospital, Chris learnt what asthma is, how to manage his triggers, what his medications do, and how to use them correctly. Chris now uses a spacer to have his medication. He also learned how to recognise when his asthma was worse and the need to follow his asthma action plan. Chris.
Any questions about this video? Nope.
Nope.
Okay. Then see, somebody just joined the class. Let me mark her down. Okay. So let's go back to sharing PowerPoint. All right, so auscultating, obviously we talked about that. Lung sounds on both sides during inspiration and expiration. So who can tell me, ideally, how to listen to lung sounds? And what I'm talking about here is, go ahead. Somebody say something? All right, so if this guy, this EMT here, if he's listening to lung sounds on this, right here in this location, if that's the first place that he is auscultating, where should he auscultate next, ideally?
The opposite side.
The opposite side. And why is that? That is correct. Why is that?
To kind of examine that portion of the lungs on both sides to see if they're similar.
Exactly. To get a comparison of the lung sounds bilaterally, so on both sides evenly. It'll tell the EMT if there's something going on with one of the lungs. So if he's sincere, he wants to go to the other side to compare the two bottom sides, as opposed to going from here up and then just zigzagging all the way around. You won't get much with that. This sequence is just better for diagnosing your patient. It gives you a better idea of what's really going on in this patient's lungs. All right, auscultating. So we talked about wheezing. We know what's going on in the passages of the airway, and we're talking right here about bronchioles, the small little tubes. Talked about crackles, stridor. We hit that up. Breathing difficulty, assure adequate ventilations. So again, what are normal ventilations for an adult? If you are ventilating for a patient that is not breathing at all, where do you want to keep these ventilations? Between what and what per minute?
10 to 12.
8 to 10.
10 to 12 per minute. Now, your patient, if they're breathing below 10 per minute, you definitely want to bring them up to at least 10 per minute. And then if breathing is adequate, use a non-rebreather mask at 15 liters per minute. And let me see who's here. James, can you please tell me give me an example of a patient that you would ventilate, and then give me an example of a patient you would give a non-rebreather mask.
So a patient who is breathing adequately, you would give them a non-rebreather mask.
Okay, that's good. So adequately, meaning like if my patient is breathing adequately, how would they be talking to me? What would their mental status be? Like give me things like that.
They would be conscious and able to. They would be verbal.
Good. So they can have a logical conversation with you. That right? They would make sense, but they may be catching their breath. Now, who would you ventilate? Who would you actually use a bag valve mask on?
Unconscious patient.
Unconscious, or if they're mentally altered and breathing below 10 to 12 per minute, right?
Okay.
Okay. Good job. Patient care, we talked about this. So in order for you to actually use this bottle for the first time, where do you want the PSI to be?
Above 2,500?
Mm-hmm. Usually in the green or 2,000. So most bottles that I've seen, they'll have a green marking, and you want it between those green markings ideally, which is 2,000. Breathing difficulty, place patient in position of comfort. Most often that's gonna be the Fowler position, semi-Fowler, which all that means, Fowler and semi-Fowler are just fancy words for they're sitting up. That's all that means. Administer, an inhaler if they are prescribed one, and administer continuous positive airway pressure. And we're gonna talk more about CPAP right now. So the biggest thing with this is that your patient needs to be 100% conscious. They cannot be mentally altered at all. And can somebody turn off their mic, please? I'll do it for you. I got you. There you go. It's gonna mute everybody. All right. Okay, blowing oxygen or air continuously at low pressure. So these patients that are getting CPAP, first of all, they cannot be mentally altered and they have to breathe on their own, okay? And most of these patients, the biggest issue with them is gonna be a fluid issue. So like your patients that have cardiac heart failure, that have that buildup of fluid in the lungs, usually these patients are gonna get a CPAP. And the way it works for these patients with CPAP is that, so these are your patients. So pulmonary edema, drowning, asthma, COPD, respiratory failure in general. But pulmonary edema, drowning, even asthma, because some fluid does build up with asthma and COPD. What two illnesses fall under COPD? Anybody? Which two illnesses fall under COPD?
Is it emphysema and bronchitis?
Yes. So bronchitis also makes a buildup of mucus as well. And emphysema is the alveoli shriveling down and losing that elasticity, which makes them less effective as far as bringing oxygen into the capillaries. So what CPAP does is that it's gonna throw, like it says here, it throws positive pressure. So it's gonna push air into your airway. And what it does is it's gonna keep your alveoli inflated because it's like blowing up a balloon. It's going to do that. At the same time, that pressure will push away any fluid around the alveoli that may be causing interference between that gas exchange from the alveoli to the capillary. So if you're pushing fluid away from the alveoli, you're gonna have a temporary change of oxygen and CO2 until the fluid comes back in around the alveoli. Does anybody not understand that? And I know I did cover this in the classroom, but it's been a while. All right, cool. So here's some contraindications. Again, contraindications are reasons why you would not want to use a CPAP. Again, severely mentally altered. They're all mentally altered because, again, they need to be breathing on their own and they need to be breathing normally. So lack of normal spontaneous respiration. So just said that. Inability to sit up, hypotension, shock. Pretty much, if your patient is normal for the most part, they can use it. If they're not mentally altered, if they're sitting up, if they can function normally but are having difficulty breathing, you can put a CPAP on them. Okay. If they're having difficulty breathing, but they are normal for the most part, besides the difficulty breathing, they can have a CPAP if needed. So some more contraindications. So nausea and vomiting, obviously, because we're pushing air into the system. So if we push air in the system and they're nauseous, they throw up, they can asphyxiate. They can have some of that vomit go into the actual lungs. Again, penetrating chest trauma, that is going to cause more damage for that patient. And we have shock. Again, if they're in shock, they're going to be mentally altered. Upper GI bleed, again, if we blow air into their system, some of that fluid that comes up, that blood can go down into their airway, and that's going to cause a bigger problem. Conditions preventing good mass seal. Side effects. Okay, actually, let's take a little 10-minute break one more time, guys, and I'll meet you guys in 10 minutes.
Hey, Mr. Mendoza, you still there?
Yeah, what's up?
I'm just making sure.
Oh, yeah.
How are we going to do all of our medical assessments and everything?
Are we talking about like clinical rotations? I think my mic was off. Who asked that question right now?
I was talking about like the medical assessments.
Medical assessment?
Yeah, how will we be able to do, like, when will class start back up to do like the physical portions?
So what's gonna happen is we're gonna do that separately, and we're gonna call you guys in starting next month, like 6 or 8 at a time, and we're gonna bring you in to do like medical assessments on a high fidelity mannequin. But I'll be sending out emails whenever we get the green light, because we still have to go through training on how to use the mannequin, because we got it just because of the situation. And I think we have training like in a week or two. And as soon as we get trained up, like the very next week, we're gonna start calling guys in and ladies in to test out.
Okay, sweet.
All right.
Hey, so like, Mr. Mendoza.
Yeah.
In regards to that, like, what will be the time frame? Because some of us start work soon, like in fire season, it kind of like takes up a lot of our time and like commitment. So like, do you kind of know yet or no?
Well, it's all gonna be it's gonna be 100% flexible. So what I'm gonna do is I'm gonna take I'm gonna set times and days, and I'm gonna ask who can come. So the first 8 that answer, or 6, however we do it, they're gonna be in. And now I'm just gonna keep posting dates, even if I have to come in on a weekend for one of you guys or 2 of you guys, whatever. Like, we'll make it work. Like, we're gonna make this work for you guys.
Okay, for sure. Because like right now, the only things that I'll absolutely have free are weekends to do that. So
Yeah, for sure. Like I said, like I'm sure like there's a good amount of you guys that are on the same boat. And if I have to come in on a weekend, then I just have to come in on a weekend. We'll work it out.
all right, cool. Thank you.
Mm-hmm. Let's see who left. All right. Let me minimize this thing. Can you guys see the PowerPoint still?
Yeah.
All right, so let's continue on. I think we're almost done with this PowerPoint. And for today, we do not have a Kahoot test, but we will for the next class, which I think is tomorrow. Yeah. Okay. So right here, they're showing you, I guess, how to place the CPAP on a patient, but I actually found a really cool video that I think I may have already showed, but it's worth showing again. So I'm just gonna go ahead and put it up for you guys. All right, here we go.
Okay, today we're going to be going over CPAP, which is used for patients in respiratory distress. It's a positive pressure that helps air movement get it in deep into their lungs. So Mike is going to be our patient, Tyler is going to be helping out, and we're going to demonstrate the steps. Basically, this is used for people who are in respiratory distress. A lot of times they have pulmonary edema, which is fluid in their lungs. So what you're going to hear when you have a patient like this is you're going to hear kind of what we call wet lung sounds, where you can just hear them kind of fluid in the lungs. A lot of times they either have pulmonary edema or what is known as CHF, congestive heart failure. So if a patient has a history of CHF and they're having trouble breathing, a lot of times this is one of their major treatments that's going to help them out. So what we're going to do So we're probably going to be getting dispatched to respiratory distress. Mike's going to tell us that he is having a little bit of trouble breathing. Sometimes you need to use a stethoscope. Sometimes in severe cases it's so bad you can just hear it as soon as you walk in the door. So what you're going to do is listen to his lungs. You can hear fluid on both sides. One of the contraindications for using CPAP is pneumothorax, which means he's not getting air movement on either one side of his lungs. So you don't, if you're not hearing breath sounds on both sides, you might want to reassess the situation, make sure it's not something other than fluid in the lungs. But he's good, so we're hearing gurgling in his lungs. So we're going to go ahead and hook him up to CPAP to try to help him out. Basically, what he's doing over here is hooking the CPAP unit into an oxygen bottle. You can hear once you connect it, the oxygen is already on. Basically, what you do from this point is, this patient's going to help us out a little bit, but you put the mask up to the patient's face. You want this seal going from the bridge of the nose down to the chin, and it's really important that you get a good seal. So you're going to, if they can, that's great if the patient can hold the mask up to the face, but sometimes they can't. You might have to have somebody hold it for him. But he's going to help us out and hold it to his face. So what Tyler's doing is putting the head strap on. Basically, all this does is prevents Mike from having to hold the thing on his face the whole way to the hospital. So what you do is you want it tight, not too tight. You don't want to make the person anxious, because they start getting too much anxiety from feeling like they can't breathe. That's going to screw the whole system up. So you want it tight enough to get a seal, but not tight enough to make them claustrophobic. So you can see he's doing the top straps first, get both sides tight. You want it to be even too. You don't want to pull real tight on this side and kind of loose on this side, or it'll kind of walk the wall on their face. So once you get both of them tight, he can now let go of the mask. You kind of want to make sure it's getting a seal. As you can see, Paul asked the patient if he was okay, make sure he's getting plenty of air movement. If they're real anxious, try to calm them down and try to tell them to take big, deep breaths. This is going to help, because a lot of people don't like the feeling of a mask on their face. But Mike said he's doing better. What you want to do is you want to assess his respirations now. Is he working harder to breathe? It should be a lot easier for him to breathe. So you should see his pulse ox going up, things like that. If he's not, sometimes what can help these patients is what we call a nebulizer, which is basically a breathing treatment of albuterol and Atrovent. And what it does is it just dilates all the vessels of the lungs, pretty much just opens them up. So if you need to run the CPAP and the nebulizer at the same time, it can be kind of tricky sometimes, but it can be done. So this right here that Tyler's holding is the nebulizer, and the bottom of it, you would put your albuterol and Atrovent. This is just saline, since we're just demonstrating. So what you want to do is you want to connect that into the bottom of the blue tube here that comes in a kit. It actually comes in a kit to go with the CPAP. So once you do that, you connect. This also needs to have its own oxygen source, so it's connected to the oxygen bottle, as you can see down there. Once you do that, you're going to have to temporarily disconnect this mask here. Good. And he should still be able to breathe. It's just going to cut off the oxygen, but you can see he can still get air movement through there. And then that piece goes, the blue piece goes inside of the white tubing. So then you want to turn the oxygen onto the nebulizer, and you can see the nebulizer here is actually, that's what it's supposed to do. It's supposed to aerate the medicine down there. So now he's getting the breathing treatment as well as the CPAP, which should really improve this. He's still able to breathe. Helping you out a lot. Help this patient out.
Any questions, guys?
No.
Nope.
What have you been doing? Just chilling here watching this shit? Oh, you been watching what is this? Beach Highs or what?
All right. Go back to our lecture. So obviously, if your patient gets worse after you do anything, you might want to undo what you just did. So if your patient gets worse after you apply CPAP, take it off your patient because it might actually, you might have actually agitated something or made something worse. Respiratory conditions. So we talked
So if it
about
gets worse, like you should stop it and then what?
reassess your patient, see what's going on, because obviously what you're doing for your patient is contraindicated. And it's all situational, but I mean, generally and just simply stop what you're doing and reassess to see what's going on with your patient. So COPD, again, emphysema and chronic bronchitis both make up COPD. If your patient sometimes if they have asthma or something called a black lung, they'll just throw them in there, and it's all a soup of pulmonary diseases called COPD. Broad classifications of chronic lung diseases include those. Overwhelming majority of cases are caused by cigarette smoking. A lot of times people that live in very industrial areas where there's a lot of pollution, that's also a factor for patients that develop COPD. So chronic bronchitis by itself is similar to that of asthma in that it's an inflammation of the bronchioles. However, with asthma, it's more of a spasming, like open, close, open, close. And also the biggest thing with bronchitis is this. This is pretty big. It's gonna be an excessive mucus production. All right, so that's gonna be key. And I will write that down somewhere as a side note. Cells and bronchioles that normally clear away mucus accumulations are unable to do so. And so this right here is just giving you an example of like the fluid that would build up. It would drip down or just to kind of settle in the bronchioles, but also in the alveoli themselves. And emphysema, so emphysema, like I said, you lose that elasticity and that surface area of the alveoli. So these right here are alveoli, and because so here it's showing, it's giving you the example that these walls right here, these walls are now lost. So they're no longer there. And because of that, we're losing surface area. And the reason that's a big deal is because the more surface area we have, the more gas exchange can occur. The less surface area, the less gas exchange. And that's why emphysema is such a big deal. Not only that, but also you're losing surface area, and you're also, the alveoli tend to sag. And they're not as plumpy as it used to be, and that also affects the surface area. So alveoli walls break down, surface area, talked about that. Lungs lose elasticity, we talked about that. Okay. Asthma, I think we talked about asthma plenty so far. So I'll just read these, and if anything comes to mind, I'll say it. But if you have any questions, like always, please ask away. So it's a chronic disease, episodic exacerbations. So a lot of kids, when they're out playing around, their asthma can be provoked, and they can go into a little asthma attack. Again, the bronchioles, sorry for that. The bronchioles are the issue here. The bronchioles are narrowing and spasming, and it's not allowing air to come in and out adequately, mainly the out part. Results in small airway passages practically closing down. Okay.
I have a question.
Yeah.
Oh, why is aspirin or asthma like a contraindication for aspirin?
For aspirin?
Yeah.
Aspirin's a contraindication for asthma?
Yeah.
That's in the book?
Yeah.
I gotta get back to you on that one. I have no
Pretty
idea.
positive I saw that on a test. Let me look it up now. Maybe I'm
Yeah, I don't think that's correct. The only time aspirin is contraindicated that at the BLS level, is like any head trauma, any recent surgeries, anything that allows them to bleed out more, any wounds pretty much. But I'll look into that. But that could be it. I don't know. It must be a new thing that I've never heard of before. But I'll look it up and I'll get back to you. All right. So emphysema, again, it's a breakdown of the walls. Elasticity is lost. Talked about that. All right. So pulmonary edema. Again, pulmonary edema. Every time you hear edema, just think of fluid in that area. So if we're talking about pulmonary edema, pulmonary being the lungs, we're talking about fluid building up in the lungs. A lot of these patients are going to be patients, like I said, they have that heart failure. And the blood that is returning to the right side of the heart from the body, from the inferior part of the body, the lower half of the body, that blood is going to back up because the heart is not taking it in because it's not pumping adequately. And that's going to settle down in the ankles, giving that patient pedal edema. Now, on the left side of the heart, just how I stated earlier, the blood is backing up into the lungs, and that is what's causing the pulmonary edema and that fluid buildup. Now, a patient with pulmonary edema, you walk into a room, let's say you're going to a SNF. So a SNF is a skilled nursing facility, and it's where people that are, really ill go, and they have nurses to take care of them. Now, you go to a SNF, you walk into the patient's hospital, patient's laying down, having difficulty breathing. What is the first thing you can do for this patient that could possibly help them out if they have pulmonary edema, and why? See, I'm gonna pick on Michaela. You there?
sorry, can you say that again?
So if you walk into a room, any room, your patient is laying down on the bed. We'll say they're on a hospital bed because they're in a facility, right?
Mm-hmm.
The patient is having difficulty breathing. You know this patient has a history of cardiac heart failure and they have a history of pulmonary edema. What's a good thing to do first, right off the bat, on this patient, for this patient?
Ask the medical control. Like, I mean, you just walk into the room, like, are they your patient?
Yeah, they're your patient. You're called for them, and when you walk in there, all you do is you see we'll say an 80-year-old male laying on a hospital bed, flat, and they are having difficulty breathing. That's it. Anybody think they know the answer to this?
Like normal breather?
Prone position?
Sit him up.
Yeah, sit him up. Put him in the Fowler or semi-Fowler position. Because if this patient is laying down and they have fluid in their lungs, if they're laying down, you're covering more surface area of the lung as a whole, and therefore there's less gas exchange. When you sit this patient up, all that fluid is gonna settle down in the very lower part of the lungs, and you're leaving more alveoli exposed, so there can be gas exchange. Does that make sense or no?
Yeah.
Okay. Okay. Pulmonary edema, pressure builds up in the pulmonary capillaries, fluid crosses, then kind of talked about that. So, like I said, if the patient has fluid in the lungs, that fluid is going to interfere with that gas exchange between the alveoli and the capillaries that carry the blood around the alveoli. And obviously we talked about this. So oxygen to reach the blood. So some signs and symptoms, dyspnea, obviously they're gonna have that. That just means that they're having difficulty breathing. So dyspnea means difficulty breathing. And if anybody's having difficulty breathing, they're gonna be anxious, right? If you're anxious, you might be sweaty. Tachycardia, that comes from both them being anxious, but also if your body doesn't feel like it's getting enough oxygen, it's going to go into what am I looking for? It's going to just try to help itself out however it can help itself out. So if oxygen is not getting to the tissue, the body might be thinking that maybe the blood needs to be pumped harder, so your heart is going to start contracting at a faster rate to kind of make up for the lack of oxygen, right? Hypertension goes hand in hand with that. That means your tension goes up as your heart rate goes up as well. Respirations are rapid and labored. So if you have gas exchange issues in the lungs, remember the chemoreceptors we talked about earlier? So those chemoreceptors, if blood is not able to cross that membrane from the alveoli onto the capillaries to get on the blood, to be carried to the tissues, if you don't have that, if that's not happening, then CO2 is starting to build up in your system and oxygen levels are starting to go down. So as that's occurring, your chemoreceptors will pick up that your CO2 levels are increasing, and the chemoreceptors will then send a signal to your respiratory center that's in the brain to increase respirations. So that's why that's happening. And obviously, as a result, you're gonna have a low O2 saturation. Any questions about that? No? Okay. Common signs and symptoms. Crackles, that's that bubbling sound we talked about. Possibly wheezing sound. And remember, we talked about this too. They're gonna have that frothy sputum. That's really common. It looks like I think I compared it to like a pink muffin, right? It looks like very frothy out of the lungs and capillaries. So CPAP may be used to push fluid back. So again, the CPAP, what it does is that pressurized air that's going into your patient's body will both inflate the alveoli to give it more surface area and push away the fluid to allow for that gas exchange to occur temporarily until that fluid goes back in or goes back in the place that it was before it got pushed away. Pneumonia, this is really just an infection in the lungs. That's all it is. So what is one thing that I am going to find with this patient that I may not find with any other respiratory issue? What is one finding?
Fever.
Fever, perfect. And that's because of the infection. Your body is trying to fight out some kind of bacteria or virus or something that is in your lungs that should not be there, and a fever will result of that, because of your immune system. Results from inhaling a certain microbe, and they grow in there, obviously. So pneumonia, a lot of your symptoms and signs and symptoms are all going to be very, very similar, especially for your respiratory patients. But again, for your pneumonia patients specifically, you're going to have your fever. They're going to have that high temperature. And because of the infection and where it's at, like any other infection, there's going to be a good chance that site is going to hurt. So they're going to have pain as well. Now, the only other, that's actually two more. There's two more situations where a patient will present pain as a result of a medical issue. The other one is a spontaneous pneumothorax, which means that the lining around the lungs somehow just bursted, and that's gonna obviously cause a lot of pain, because the pleural just ruptured. And the other one that I could think of is trauma. That would be a punctured lung, but that's trauma. That's not even medical. Let's see, fever. So, oh no, actually, a pulmonary embolism. So a pulmonary embolism is the exact same as a heart attack, except that it's a lung attack. Because in a heart attack, what you have is you have a coronary artery, a vessel that's clogged, right? So blood can't get to a part of the heart, and then angina comes as a result, and that angina is pain because of a lack of oxygen to a part of the heart. Well, a pulmonary embolism, pulmonary embolism, that just means that you have a clot in one of the vessels of the lungs, and pain will result from that. Any questions about that? Okay. Pneumonia, headache, pale sweaty skin, fatigue, confusion. So a lot of treatment for just BLS ENT is more supportive than anything else. Your job is just to keep an eye on the patient before while they're en route to the hospital. Assist as needed at the basic life support level, and that would be giving them oxygen, assessing their vital signs, breathing included. And then also spontaneous pneumothorax. Oh, that's cool that it was back to back. So pneumonia and spontaneous pneumothorax both will have pain associated with them. And again, like I said, you have this membrane that surrounds the lungs, and whenever that ruptures, air escapes the lungs and goes into the chest cavity where it does not belong. And that's going to cause agitation, which is pain. And these tend to be tall, thin men usually. Usually it'll be a tall, thin man, and it will be from like applying too much pressure for something. So like your patient that was working on his car, right? They were changing out a tire or anything, and they applied too much pressure with their arm. Sometimes that causes the pleura to rupture. Why exactly? I don't know. I have my ideas as to why, but it has to do with them applying pressure and the muscle contraction in their system, in their thoracic cavity. So spontaneous pneumothorax. So first off, spontaneous pneumothorax, is this patient gonna get a CPAP? What do you think? Yes or no?
No.
No.
No. Why is that? Good answer.
It's
Why not?
dangerous?
Very dangerous. So this patient has a rupture, meaning a cut around their lungs. And if you apply pressurized air, you're gonna make that cut even bigger and worsen the injury. And that is why you do not do that. You would definitely, there's a good chance you can kill this patient from applying too much pressure in the chest, because that pressure can build up and not escape to the point where it causes obstructive shock. Remember what that is? And that's that pressure on your heart from the thoracic cavity. So that's why that's a big deal. Obviously, your patient, they're gonna have pain. We talked about that. They may have decreased or absent lung sounds on the side of the injury. So that's why you want to compare the both sides equally. Very important. Obviously, shortness of breath. Every breath this patient takes is gonna hurt. Low oxygen saturation and tachycardia. Talked about that. Treatment, there's nothing you can do really out in the field. Just transport them to the hospital, get them there as soon as you can, safely. Give them O2 via non-rebreather. And like I said, CPAP is contraindicated for this patient. So we already covered that. Oh, and then pulmonary embolism. Perfect. The other one that causes pain. And like I said, it's a blockage in blood supply to lungs. So a vessel in the lung system is obstructed, and because a certain part of the lung tissue is not getting oxygen, it's gonna send out a signal of pain for you to do something about it. Just like your heart causes angina, your lungs and every other part of your body has their own form of angina. You just don't call it angina. Commonly caused by deep vein thrombosis. So what that is that you possibly had like a clot that formed. It could be like a blood clot. Sometimes blood clots just forming in the blood. And if that happens somewhere like in your leg, and it could just travel down into your heart and eventually end up in the small vessels of your heart, and that's how a clot happens. So that's pretty common. That's why it's on here. But it could be a number of things. It could be plaque, like we talked about. It could be a number of things. This is just a very common example. Increased risk from limb immobility, local trauma, or abnormal fast blood clotting. So it says that a pulmonary embolism, you have an increased risk from limb in mobility. And the reason for that is that if your blood is not continuously pumping, if you're not active and you're staying still for so long, what happens is that because your blood is not moving very fast, sometimes clots tend to form. So your platelets start to just kind of chunk up together because it's moving so slow. And eventually those little clots can end up in your heart. Any questions about this? No? All right. Pulmonary embolism, again, they're all pretty much the exact same as your spontaneous pneumothorax. Again, same treatment. Go take them to the hospital as fast as possible. Give them oxygen. So epiglottitis, who am I gonna see this with the most, guys? Who gets this? Which patient? See, James, you there? Can you tell me? Is James even here? We asked people leave us.
Is it children?
Yes, children. Children, they'll get this the most. And that's just swelling in the upper airway in the mouth.
Yeah, in the book it says that it's much less common in children nowadays than adults just due to vaccinations.
Oh yeah, but you'll see this with children more often than not. I mean, at least as my experience goes, it could be changing.
Gotcha.
Yeah. Let's see. Let's watch this video. I gotta share my screen for this. Just give me a second, guys. New share. I think it's that. Oh no, it's this one over here. Can you guys see the video?
Yep.
Yeah.
All right. There we go.
Emphysema and chronic bronchitis are chronic obstructive pulmonary diseases, disorders mainly of middle-aged or older patients, in which tissues react to smoking, other pollutants, or repeated infections. In chronic bronchitis, the bronchial lining is inflamed, excess mucus forms, and cells are unable to clear away accumulations because the cilia are damaged. In emphysema, the walls of the alveoli break down, reducing the surface area. The lungs lose elasticity, and stale air laden with carbon dioxide is trapped in the lungs.
All right. Pulmonary edema, I think I hit that up. I think, am I going backwards? Talked about that. Oh, something has set me way back for some reason. All right, here's another one on spontaneous pneumothorax from the chapter. So I'm gonna go ahead and share this one as well. Let me. All right, here we go. Here's the next video.
A spontaneous pneumothorax often occurs as the result of the rupture of a subpleural pulmonary bleb. A bleb is an area of weakened lung tissue, most often located in the apices of the lung that fills with air. As a bleb distends, its wall weakens and wall tension increases. Like an expanding balloon, the bleb will eventually rupture, creating a pneumothorax. Air then travels down the pressure gradient and enters the pleural space, and the lung collapses. The resultant ventilation perfusion mismatch and decreased tidal volume then lead to dyspnea and hypoxia.
All right, so as far as prescribed medication, you have your albuterol inhaler for your patients. It's already pre-measured medication, usually 2 pumps, and they are good to go for the most part. So you have patients that take it like this, and you also have patients that have a spacer in between their mouth and the actual device. Before administering, obviously check your rights. So is it the right patient? Is it prescribed to them? The right time, right medication for the patient, for the condition, right dosages, and right route. As far as BLS goes, I'm sorry, excuse me, guys. Right dosage, everything's already pre-dosage, so that's something you don't really have to worry about in the BLS level. But obviously check expiration dates. And then you do want to shake inhaler before giving it them to kind of mix up the medication in there. Patient alert enough to use inhaler. And then that's just a picture of the albuterol. That's the nebulizer you guys already saw. Sometimes if the patient's inhaler is not working for them, or if they do not have it and they're having some kind of asthma attack, we give them a nebulizer. It does the same thing as the albuterol. And let me play this video for you guys, see what it's about. I haven't seen it yet, so might be helpful. New screen.
Administration of life-saving medications in the pre-hospital setting may be one of the most important things an EMT will do for their patient. It requires the ability to recognize life-threatening conditions.
You guys see it?
Yeah.
All right.
Such as administration of life-saving medications in the pre-hospital setting may be one of the most important things an EMT will do for their patient. It requires the ability to recognize life-threatening conditions, such as hypoglycemia or an asthma attack, knowledge of which medications are used to treat these conditions, and how those medications are administered. Some medications can be administered by the EMT, such as aspirin for chest pain and oral glucose for hypoglycemia, while other medications, such as nitroglycerin for chest pain, bronchodilators for difficulty breathing, and epinephrine for allergic reactions, must already be prescribed to the patient, and the EMT will only be assisting the patient with his or her own medications. A metered dose inhaler, or MDI, administers a prescribed dose of medication, usually to a patient with a history of chronic pulmonary disease, such as asthma or COPD, every time the inhaler is activated. The most common medications administered by this route are bronchodilators, which are drugs that dilate or relax the smaller air passages, making it easier to breathe. Because patients are becoming hypoxic during an acute respiratory emergency, they often will be agitated and unable to follow directions well. Therefore, you may be requested to coach or assist the patient in administration of their metered dose inhaler. Most bronchodilators begin to work immediately, and their effect can last for hours. The device through which these drugs are administered consists of a metal canister and a plastic container with an attached mouthpiece. The metal canister holds the medication and fits inside the plastic container. When depressed, the device delivers a metered, or an exactly measured dose of medication. The patient must coordinate their inhalation with activation of the device so that the drug will deposit itself into the bronchioles. Because the coordination can be difficult at times, some metered dose inhalers come with a chamber or spacer that attaches itself to the plastic container. The chamber holds the medication until the patient inhales it. Once you have determined that the patient is in respiratory distress, as evidenced by shortness of breath, tachypnea, tachycardia, cyanosis, moist skins, accessory muscle use, presence of wheezing or silent lung sounds, and or is tripoding and has their prescribed MDI with them, follow these steps. Take MSI precautions. Explain the procedure to the patient and get his or her consent for an assist if needed. Keep in mind the 5 rights involved in administration of any medication. Ensure that you have the right patient, which is one in respiratory distress, the right drug, which is a bronchodilator, the right dose, which will be metered, the right route of administration, which will be inhaled, and write time, which is now, while the patient still has their own respiratory drive and can follow directions. Shake the canister vigorously for a few seconds. If the patient is wearing an oxygen mask, remove the mask. Instruct the patient to hold the inhaler upright in his or her mouth with the thumb on the bottom of the canister and the index finger on top. If the patient cannot do so, then you should hold the inhaler. Tell the patient to take a deep breath and to exhale fully. Have the patient quickly place his or her lips around the mouthpiece, making a tight seal. Direct the patient to take a deep breath slowly over a 5-second period. Simultaneously, either you or the patient should depress the canister. Make sure the patient has started inhalation before the canister is depressed. Remove the inhaler and request that the patient hold his or her breath for 10 seconds or as long as possible. Coach the patient to exhale slowly with pursed lips. Replace the oxygen mask. The medications in MDIs usually cause an increase in heart rate, as well as a feeling of nervousness or shakiness. You may also hear more wheezing now that air is able to move through the bronchioles. Reassure your patient, but also be sure to document your findings.
All right. Small volume nebulizer. You guys already seen that whole video, and they explained it pretty well. So I don't think there's a need to cover this. And that's it. that's it. All right. Any questions, guys, at all?
Nope.
Nope. All right. Since I have you guys all here, I am going to send you guys a link real quick. And can I have you guys just take the survey? They asked us to send you guys the survey so you guys can fill out. But let me exit out of here first and show. You know what? We'll just do it next class. I'll do it first thing next class. All right.
Sounds good.
All right, guys. So we'll meet tomorrow at 7 p.m.
Alrighty.
All right.